Thank you very much, and sorry for the delay. So talking about delirium and end of life, my whole work focus is obviously geared towards patients at end of life, but I think we have a lot of commonality. So I'm going to try and hopefully cover some of that common ground that we have, that all you people have in the areas that you work in geriatrics. So this is my disclosure. I don't have anything of any great interest. Certainly there's no conflict of interest. The supports that I have are disclosed in this slide. The objectives, I think, I've actually going to stray a little bit outside the objectives. These were an objectives, a set that I sent over for last year's presentation to the civic group here. I'm going to talk a little bit about prevention, because I think that's a common ground that we share. And some people would think, you know, just because you work in palliative care, why would you even think about preventing? But I want to try and convert the world into thinking that there is some worth to looking at prevention. I have to talk a little bit about management as well. And the opioid neurotoxicity, I want to cover a little bit about that as well. So let's roll on. So much of this, I think you're quite aware of. Delirium is certainly spans all specialties, often referred to as every man's psychosis. So somebody, almost certainly, if they haven't experienced delirium themselves, would have seen it perhaps in a family member, even as a kid. I often use the example as a kid with a fever, for example. You know, you'll see it. But much of the development and knowledge expansion over the course of the last decade relates to a lot of work that has been done in ICU studies. There's a huge interest now, because I think people have copped on the cost, the morbidity and the economic cost associated with delirium is huge. So the administrators and the research funders, etc., have copped on and realized, you know, we need to put some money into researching this to try and bring down this cost and to improve quality of life for patients. Palliative sedation, I'm going to talk a little bit about at the end. It's a rather controversial treatment, so I'm going to cover a little bit on that at the end. Sorry, where do I move on here? So, what are the main issues in terms of our overlap? In other words, palliative care in the elderly population. I think the epidemiology and looking at the actual figures, and I think you guys probably need little convincing of this. You know what the numbers are like, but I'll show you some slides in a minute that outline the demographic changes. The major risk factors for delirium in this population are obviously comorbidity, frailty, dementia, existing dementia or evolving dementia, and cancer prevalence, because cancer is predominantly a disease of the elderly, not exclusively, but predominantly. I'm going to talk a bit about reversibility as well, and as I said, management. So again, I'm trying to catch up on a little bit of time here because we're behind. So these figures, again, you guys are probably very much aware of this. The graph is going in this direction, right? The numbers that we're going to deal with an elderly population certainly expanding. And cancer, much of what I see in palliative care, I see cancer is the sort of predominant illness, the patients that we see in palliative care, largely because it's an easier one to map out. The trajectory, the course that they have, is easier to map out. So we've ended up, and traditionally palliative care sort of emerged out of supportive cancer care. But there has been the war on cancer, and there is no doubt that the actual rates of death, when we talk about rates, we talk about numbers of deaths per 100,000 of the population. So a rate is different than a total figure. So you'll see here that the rates, projected rates are going right up, okay? And this is another slide here where it shows you the actual, the actual numbers. These are the numbers of deaths, okay? And this is the actual rate, the standardized rate. So this is the deaths in the color. Okay, so the actual numbers are going up. Because there's a shift into the elderly portion of the population, we're actually dealing with bigger numbers. The actual rate of death is going down, but the numbers are actually going up. It sounds contradictory, but it's very real. So how common is delirium in palliative care? This was a systematic review done by Anne-Marie Hosey as part of her PhD, published back in 2012. And you'll see the prevalence on admission goes from about 15% up to about 42%, I think it is. And maybe slightly higher delirium prevalence reported during admission. And then the incidence of delirium, studies that have looked at new cases, followed patients and looked at new cases, ranges anything from 5% up to just above 40%. But again, this very much depends on the setting of care. It depends on the criteria for diagnosis, etc. And then lastly here, I always tell patients that 10% of patients in the study, one of our studies is included in this here, and we found 88% of patients, when we followed them to death or discharge, had delirium present in 6 hours, at least 6 hours before death. So it is very much associated with the terminal phase, but I wouldn't want you to run away with the impression that delirium is all terminal. There is a reversible component, as you guys probably well know, and it's very important to keep that in mind when the goals of care will accommodate an effort at reversal. So, what are the factors the simple things that we might be able to tackle in terms of delirium reversal, and what are the precipitants? This is a report actually based on Ontario data. It was published, I think, 2010, and looked at prescribing and compared 1997 to 2006. And if you look at the proportion of patients, you can see this major swing towards 2006 for increasing use of medication classes. And when they looked more closely at this, so dramatic increase. We tend to reach physicians reaching for the pen, prescribing more. So what do they prescribe? Well, the increase in psychotropics has gone up 254%. Analgesics, opioid analgesics, corticosteroids, these are just examples. But again, it's just reflective of what has happened in that particular decade, comparing 1997 to 2006. So I suppose the great champion of prevention of delirium really comes from geriatrics, and that would be Sharon Inoue. And she presented here, I think back just a few years ago. Barbara Power had her here a few years ago, and I remember her presenting. But this was one of her seminal studies, a prospective study that looked at multi-component interventions, 6 factors, tackled cognitive impairment, sleep deprivation, immobility, visual impairment, hearing, and dehydration. And very significant reduction here in the incidence. This is the cumulative incidence of delirium over a 7-day period. I think it was a 30% reduction here. So very significant change with that intervention. There have been some recent studies looking at prevention, and this is a systematic review just published last year. 7 studies only included, but almost 1,700 patients. Multi-component interventions, reduced incident delirium, relative risk down to 0.73. So very significant reduction. Non-pharmacological multi-component interventions. So it's something that should really be built in as part of the holistic model of care. Non-pharmacological multi-component interventions. This is a Cochrane review actually from this year, mainly a group I think from the UK, the names that I recognize anyway. Again, significant conclusion was very definite that multi-component interventions reduce the incidence of delirium. What I want to highlight in this slide is that there was no clear evidence that cholinesterase inhibitors were of any benefit. So, and I have another slide coming up shortly that will comment on that as well. Also, there was no clear evidence that antipsychotic medications reduce the incidence of delirium. And there was no clear evidence that melatonin or melatonin agonists reduce the incidence of delirium. Now, I think this may have been published before. I have a melatonin study to show you as well. So, in palliative care, before I came to Ottawa in 2010, there was a study done looking at a multi-component prevention strategy and included deprescribing. It was a negative study, sadly to report, but I think there were major methodological issues with the actual study. So I think it should not in any way, and it certainly would not deter me from looking at another study at preventing delirium in this population. This was a study by the geriatric group in London, Ontario, Mandeepa Dasgupta and crew, Chris Brimmer. They looked at a low dose of melatonin, 0.5. It was a very small dose of melatonin that they gave to patients who were admitted, medical patients, and looked at the incidence of delirium. And it was an RCT, may not have been adequately powered, but certainly showed a difference, and certainly preliminary data was impressive, a reduction from 31% to 12% in the group that got melatonin. So this prompted us to look at melatonin in palliative care. Now, sadly, I don't have the results, but we actually have just finished a feasibility RCT on melatonin versus placebo in palliative care setting. Meanwhile, in 2014, JAMA Psychiatry, Ramelteon is a melatonin agonist. And this was a study that showed a very definite and impressive reduction in delirium, incident delirium, in the group that got Ramelteon. How might melatonin work? Very good question. I mean, obviously, it's got its association with sleep and with the diurnal rhythm and the sleep-wake cycle, but it also is an anti-inflammatory, so it has anti-inflammatory components, so it may actually work. That I'm just saying could, speculative. But I think it's still worth a trial, and we're certainly looking at doing a bigger RCT, and we're also involved in an Australian RCT looking at the same thing. So this was a nice article written in JAGS back a few years ago by Nikki Quinlan, and looking at the overlap with frailty and delirium. And I think this is very much reflects much of our patients, many of our patients as well, have frailty as a huge issue. And I'm not sure that we've, in palliative care, that we fully have grasped it in the same way as geriatrics has grasped it. Having said that, there's issues when I look at the literature of how frailty is recorded and what measures you use to record frailty as well can make for significant differences in your reporting of data and outcomes. This was a series of papers that we published. How are we doing time-wise? Not too bad. So this is a series of papers that we published back in 2014. It was a major meeting that we had, and we had a lot of geriatricians and geriatric psychiatrists and delirium researchers from around the globe who came to us, and we basically published 8 papers called a SUNDEP series, Studies to Understand Delirium in Palliative Settings. It was really sort of to map out a sort of a research agenda, and we're moving on from there now, doing a scoping review of the literature, an international survey, and certainly we're open to, if there's keen people to collaborate with us, we're certainly open to do that. So the actual studies look at, this is the map of the course of delirium. In other words, you're looking at the sort of screening, prognosis, diagnosis end here, then how we manage it, standard of care versus care guided by outcome risk prediction, the various therapeutic strategies, symptom control versus looking at, reversing, etc., and then the outcomes. So rather complex diagram, but just to summarize, just to say that that's something that we're very much working on. So what can happen with an episode of delirium? It can either not reverse, in which case it becomes chronic, or a terminal episode. In palliative care, certainly a terminal episode, and usually people will not survive too long if it's non-reversible. It can become partly reversible, and you guys are probably very much aware of this, because I think even though we talk about the reversibility of delirium, very often the data from the literature would suggest that many of these patients, when we talk about reversal, they may not completely reverse. They may function at a step lower on the scale, and as time goes on, repeated episodes, and their functioning is a little bit lower still. So, or it may be a reversible episode. These are the 3 potential outcomes. And much of this is determined by, obviously, etiology. If somebody has extensive metastatic disease and multi-system failure, hypoxic, we're not going to be able to reverse it. But if they're hypercalcemic and we give them bisphosphonates, or if they're opioid toxic and we switch their opioid, there is the possibility of reversal. A lot depends on the desired goals of care. So some of our patients will come to us and say, I don't want any blood work, I don't want any tubes, I don't want any antibiotics, I don't want a transfusion. We have to respect their wishes. So clearly, goals of care will determine a lot as well. So I show this, and those who were here last year when I presented saw this. I often put it up. I ask people, it's great to show to a European audience, because they say, this guy's from Canada, so this is ice, right? So everything is ice, and even if you show it in the States, of course, everything, we all live in igloos up here. So I ask them, what do you see? And the response, the usual response, almost overwhelmingly, everybody says, oh, this is ice or snow. And I ask them, I say, well, what season is this? And I say, oh, it's winter. And I then move on to the next slide. I say, what season do you think it is? And then they see the little bit of green up here, and they maybe think twice, and they wonder what the heck the car's doing here. This is actually June in Edmonton. So this is a hailstorm, so you got coalescence, right? The message is, if you take an approach that is totally fatalistic with delirium, and you say every episode is non-reversible, it's going to become a self-fulfilling prophecy. So what you see, you need to think carefully about what you see, and not just jump too fast to conclusions. That's the message, essentially. So we talked a little bit about reversibility, or as Demetrius and crew here talked about recovery from delirium. They actually did a systematic review because they were intrigued by what do people mean by reversal? What do they mean by recovery? And the truth is we're probably all over the map. They had 56 studies. Only 2 studies used clinical criteria alone for the diagnosis of delirium. And basically, there isn't a great level of agreement to define recovery from delirium. So, again, interesting just to show how, you know, when you go to look at the literature and trying to make sense of it, when you see what one person's definition of recovery is and another person's definition, that there isn't a consistency. Now, Martin Cole is a geriatric psychiatrist working in Montreal, and he's published extensively on delirium and done some of the most fantastic studies, actually. And this is looking at recovery, reversal recovery from delirium in older hospitalized adults. This was the defined recovery here as full recovery, absence of the CAM core symptoms of delirium, partial recovery, presence of one or more CAM core symptoms but not meeting criteria for delirium, and then no recovery. So you'll see the difference here, obviously, between the dementia patients and the no dementia patients. Partial recovery, no recovery, and death, which was higher in the no dementia patients. And this is just a graphical illustration here. So you're more likely, the full recovery, obviously much higher in the no dementia patients. So in palliative care, we are obliged, very much, big part of our work is working with the family as well as the patient. And sorry, I'm just got thrown by this new, because all my slides are all jumbled up with the file was too big and we couldn't open it this morning. So anyway, we'll move on. So this is the looking at delirium as an experience. This was a study done by Bill Breitbart and Sloan Kettering in New York, looking at 54 dyads of, or should we say triads. It was basically patients, their nurse, and their spouse, and looking at the perception of distress during delirium when they had recovered, okay? So the patient, or the person, the individual that found it most distressing, reflecting back, was the spouse. So if you see your other half hallucinating, agitated, confused, trying to climb out of bed, do crazy things, it's very distressing. So there's no question about it. How do we interpret that distress in palliative care? And how do we relate that to pain management? It is very, very difficult. And sometimes we're simply not sure, in all honesty. We don't know how much of the agitation may be part of a delirium, how much of it may be increased pain, because we know that increased pain is a risk factor for delirium also. So it gets very complicated. And this was a part of our study in Edmonton, one aspect of it where we looked at breakthrough doses. Normally we give 10% of the total daily opioid dose as breakthrough hourly if needed, okay? And so it's a standard for all patients. So when you look at patients without delirium, this side here on the right, you'll see that most of their breakthroughs are in the daytime. Probably when they're more active, obviously. Hopefully they sleep at night. But still, the breakthroughs, 23% of them are at nighttime, 38% in the evening. This is for patients without delirium. But swing over here to patients who have delirium, and you see that there's a push towards evening use of breakthroughs and nighttime as opposed to day. So there's a significant difference between the two. So the message is, I suppose, from a nursing perspective, is when you see somebody who's agitated and trying to climb out of bed and very distressed, how much of this is pain? How much of it is part of the natural presentation of delirium? It's a difficult call. And I think what the nurses said to us was, if they're in doubt, they may give both an antipsychotic and an opioid breakthrough dose. Now, we'll come to the antipsychotics. That's another issue as well. So we talk about opioid-induced neurotoxicity. And it is a rather loosely described phenomenon, I suppose for want of a better word, in the literature, because back in the 1980s, there was a big drive. The WHO pushed prescribing opioids. So before that, there was a terrible fear. There was major opiophobia. So this big educational drive pushed opioid use, and appropriately so. But I think it's like a lot of things in medicine. The pendulum swings from one extreme to the other. So a decade later, in the 1990s, you had increasing reports, many of them from Northern Europe, where they used very, very high doses of opioids, increasing reports of opioid-induced neurotoxicity. And that consists of delirium or subsyndromal delirium, myoclonus, allodynia, which is pain on touch, hyperalgesia, which is a heightened response to a painful stimulus, and even seizures, when you get sufficient neuroexcitation that you actually get seizures. This was our study from Edmonton, where we looked at a prospective study of delirium. We published in Archives quite a while ago now, but it's I think I was just looking the other day, I think it has 600 citations, so it's still, it was a hard study to do, and it's a hard study to replicate as well. But we found that in a palliative care population, that you had a range of, we think of delirium, I suppose, in terms of etiology, we think of baseline vulnerability, like age, nutritional status, and then you've got some sort of precipitant, some episode, some trigger that happens, and that can be an infection, medication, some acute triggering event. And we found that there was a median of 3 precipitants per episode of delirium. But the range went from anywhere from 1 to 6. So very much multifactorial, and we have to think very laterally. And the message is, and as I say to the residents that work with me, if you see somebody that you think is opioid toxic, you better think about other things besides opioid toxicity as well. You think about infection, so you have to think laterally. We found, in terms of reversibility, psychoactive drugs were strongly associated with that. In other words, that we made changes with psychoactive drugs that likely were associated with reversal. Hypoxia was associated with, somewhere here on this list, sorry, it's very blurred now. It's an old study, getting a bit like myself, blurred. So, again, hypoxia was associated with non-reversal. Independent associations here. This is a multivariate analysis. Now, there were other studies as well that looked at psychoactive medications. This is a group in Laval, and they found that basically a dose of benzodiazepines above a lorazepam equivalent of 2 milligrams per day, or steroids above 15 milligrams of prednisone equivalent, dexamethasone equivalent, and opioids above 90 milligrams per day, morphine equivalent, were associated with delirium. So medications are wonderful on the one hand, but they can be major culprits when it comes to delirium. This is a systematic review. Again, Manodipa Dasgupta from London looked at why you get prolonged delirium. And overall, studies suggested that delirium is often persistent at discharge or beyond, and persistence is associated with dementia, increasing comorbidity, severity of delirium, and particularly hypoactive subtype, and hypoxic illnesses. Our study our prospective study was one of the ones included in this. So again, as I say to you, we're looking at a baseline vulnerability. Sharon Anui was the first person, I think, to sort of preach this whole sort of concept of baseline vulnerability and then an acute precipitate. Now, all of us have some, well, to some degree, have protective factors. So the biggest protective factor, I think, probably is if you have a younger brain. So if you have somebody in their mid-20s and they get a urinary tract infection, they may get the symptoms of urinary tract infection, but if they're in their mid-80s, they may not be able to even express those symptoms, but they may simply present as a delirium. Looking at the, we're not going to go into this, but one of the things, there's a lot of work being done on the background, animal work being done on delirium. And some of it is absolutely fascinating. It's incredibly complex. When traditionally we've thought about the pathophysiology, we've talked about an imbalance between dopaminergic transmission in the brain and cholinergic transmission. That's incredibly simplistic. It is way more than that. That would have been traditionally how things were viewed. So in other words, that there was an increase in dopaminergic transmission and a relative decrease in cholinergic transmission. And the reason why we give medications like haloperidol, which is an antidopaminergic agent, is to try and correct that balance. Now, there's lots of other things going on, and particularly this is very interesting, this whole inflammatory one, because for the patients that I see, most of them with cancer, this and the blood-brain barrier, changes in the blood-brain barrier are huge. And I think this is an evolving picture, but that's as much as I'm going to, well, two more slides on it. This is just looking at the blood-brain barrier here and just looking at permeability. And the microglia are the scavengers in the CNS, right? And if they get active, they can certainly cause a lot of, associated with a lot of cell breakdown. And this is a slide from the Lancet back in 2010. And if you just look at a normal situation, and this is just the example that I just gave you of somebody in their mid-20s versus somebody in their mid-80s. If you look at a systemic infection and you get tumor necrosis alpha that crosses into the blood-brain barrier, the microglia, which are the scavengers, are inhibited by cholinergic transmission. So if you have dementia, where you have decreased cholinergic transmission, you're more at risk of the microglia being more active, okay? But if you get any infection and you get this crossing the blood-brain barrier, you can get activated microglia, and they can cause problems. So in this situation where you have somebody has, more at risk, where they have got reduced cholinergic inhibition, they may be at risk of a more severe or prolonged delirium and ultimately dementia. It's a very simplistic overview. I totally accept that, but I think it's a good graphical illustration of what might be happening in the background. And this is a study on rivastigmine, a cholinesterase inhibitor, negative study. We don't use it, so for delirium, right? So getting on to antipsychotics. This was a study by Ed Marcantonio and group. It was a database in the US, 300 hospitals, over 2.7 million patients. And the use of antipsychotics, bottom line, just in summary, is that they're used very extensively. They're used very extensively in patients with dementia and used very extensively in patients with delirium. What is the evidence base to support antipsychotics? Well, I would say the evidence base is getting poorer by the day. for the most part. And now, I have to say some of that with caution. There is certainly some studies, but the evidence, for example, we will use, as long as the oral route is available to us, we'll certainly use a medication called quetiapine, which is Seroquel. And we certainly, this is only a pilot study. I looked and they didn't ever follow up on this as a pilot study. Positive pilot study, but they didn't follow up on it. So, back in about 2006, 2005, 2006, I got a phone call from Australia from a group there wanting to look at conducting a study. They had formed a clinical trials group and they wanted to look at haloperidol versus risperidone to treat delirium. That was the initial idea. When we looked at the literature, we found that there was no study in the literature that showed haloperidol was better than placebo. So that was a hard one for us to swallow because it was very difficult in palliative care to think that you would just give somebody placebo if they had delirium. Anyhow, bottom line is we worked around it and we used midazolam as a breakthrough for those patients who got the placebo in this study. But we conducted an RCT that took us 8 years to complete. It's taken us about 2 years to report it fully. It's done the rounds of journals. It's currently with JAMA Internal Medicine. It's on a secondary review. Hopefully will be accepted by them. We used the outcome measure in this study as the NUDESC. Some of you may be familiar with the NUDESC. It was a measure of delirium. Some of you may have heard of the confusion rating scale, which is an older tool that's used to rate delirium. Nurses use it to rate delirium. The NUDESC is the Nursing Delirium Screening Scale. And basically, it has 3 items that we're used in this study, which is inappropriate communication, inappropriate behavior, and perceptual disturbance. And they're rated by each nurse in relation to an 8-hour shift that they work. So 0 is not a problem during the shift, 1 is a mild problem, 2 is severe. 3 shifts in 24 hours, we get a full 24-hour picture. It's right up front where the action is, where the patient is. We've been criticized for using it as a tool because of its validity, but it's a very difficult situation. How do you validate in this situation? For our patients, to use a more elaborate tool would have been meant more burden for our patients. So that's why we opted for an observational tool. So patients were randomized to get any one of these 3 medications: placebo, risperidone, haloperidol. And those over 65 had their dose reduced to 2 milligrams in 24 hours max. Those under 65 were given a little bit more. So 4 milligrams of haloperidol in a day is a moderate dose, I think it's reasonable to say. And similarly for risperidone would be a moderate dose. So all these 3 arms look fairly well balanced from the outset, from the beginning. And we did there's a lot of comparators across the 3 groups, but fairly well matched. So what was the outcome? Well, when we looked at, this is a rather complex model, but I think the graph gives you the answer. This is the delirium symptom score, the 3 items that I told you about: inappropriate behavior, inappropriate communication, and perceptual disturbance. So the nursing score on these items. And it did improve with time. All patients were treated with an approach to reversing delirium. And people, if they were blinded as to whether they were on any one of the 3 treatments. And they had backup with the placebo arm had backup with midazolam as needed. So this is a regression model, a random effects model, adjusted for the intervention, which is whichever arm they were in, gender, age, diagnosis, cancer, non-cancer, comorbidities, prior cognitive impairment, and functional status. And you can see from this here that the placebo arm here had a lower score. They did better than the risperidone on the haloperidol. Probably not a big surprise to some people in geriatrics, because you guys have been preaching this for some time. And increasingly, I think it's going to be shown as well in the ICU setting. Some caveats. One big caveat is that these patients didn't have severe delirium. They had mild to moderate. What do we do if somebody is severe and they're really, really agitated? We may need to intervene then. I'm going to, in the interest of time, I want to give you a few minutes to ask questions, but this is a summary David Marr published in 2013. Basically 10 issues in delirium pharmacotherapy, what we need to look at. And again, it's just looking at efficacy, the subtypes of delirium, how well they respond, what is the optimal duration of treatment, what comparisons have there been, comparison studies have there been between treatments, what are the mechanisms by which they work, how should we measure treatment response, etc., adverse effects, etc. So guidelines, you're probably familiar with the NICE guidelines in geriatrics. They were written without any palliative care input. So technically speaking, they don't apply to palliative care, technically speaking. But I think they're wonderful guidelines. My only concern is that they're so big. I mean, I think I downloaded the file, and I think was it 600 or 700 pages, I think, initially. So, you know, the thing is that it's one thing to write the guidelines, and it's another thing to implement them in practice. There are other guidelines as well, looking at specifically for patients in palliative care, and this one here, published in Canada, Susan Brightman from Ottawa, David Wright from Ottawa, David Hogan, Calgary, Pierre Allard, a colleague who passed away sadly a few years ago, all developed these. And they did mention antipsychotics. Haloperidol is the drug of choice, which should be chosen according to target symptoms, treatment goals, and pharmacological profile of the drug. And they recommended low dose, okay? That was back in 2010. I do think with the study that we're hopefully going to get published in the next little bit, we may need to go back to the guidelines again. I think we need to go back to the drawing board. So what happens, this is part of the guidelines as well, this is my segue to palliative sedation. Sedation is a deliberate reduction of consciousness to alleviate intolerable suffering. It's ethically complex and decision involving. Its use needs to be arrived at carefully through active involvement of the patient and family and other members of the healthcare team, and consultation with palliative care specialist is recommended. So it's a bit of a last gasp effort. And some people will say, well, if you're going to sedate somebody, that's just killing somebody, isn't it? Oh, no, it's not. The evidence would suggest that, and this is a systematic review published in the Journal of Clinical Oncology just a few years ago, that there was no direct evidence that palliative sedation, when appropriately indicated and appropriately applied, speeds up death. It doesn't. The underlying disease process brings about death. Palliative sedation, all it does is reduces awareness of distress. And delirium is the top indication for most patients. Simply, and this would be a terminal, non-reversible delirium. And the medication that we most commonly use is midazolam. Sadly, you see morphine here on a list, which is not really, it's used as should be used as an analgesic. It's not something that should be used to sedate somebody, per se, because it has its side effects. We mentioned opioid neurotoxicity earlier. The European Association of Palliative Care has a framework for use of sedation in palliative care. Again, this is just a definition of what palliative sedation is, but they talk about important steps in the process in which you discuss palliative sedation. So preemptive discussion, indications, consent. You need to take time with family and explain to them the implications, especially what are you going to do with hydration, and feeding, because there's strong emotions around both of those. The criteria to be met is that somebody has progressive incurable illness with a limited life expectancy, and death is usually imminent or expected within days. They have refractory or intractable symptom or symptoms, and all attempts have been made to control. And you've got an informed consent, and you have a DNR in place. So it is part of the care. Existential distress as a reason for palliative sedation is a more complex issue, which I don't have time to talk about. This is the issue of hydration here. People, as they get to the last hours of life, hydration is irrelevant because assisted hydration is irrelevant because it's more of a burden than a benefit. Because naturally speaking, their intake will go down. So it shouldn't become an issue, but it has to be discussed with families beforehand. This is a thing on guidelines. I'm going to leave you there. Sorry, I've left a few minutes for questions. I'm sorry, we started late, so I tried to catch up.